A patient presents with severe burning pain on one side of the chest. 2 days later, vesicles appear, but only along a single dermatome. This is herpes zoster. Herpes zoster does not occur from a new infection. It happens when varicella-zoster virus reactivates years after primary infection. It is an enveloped, double-stranded DNA virus, human herpes virus 3. After chickenpox, the virus remains latent inside sensory nerve ganglia, most commonly the dorsal root ganglia or the trigeminal ganglion. As long as cell-mediated immunity is intact, the virus stays silent. The virus reactivates, travels down the sensory nerve, and infects the skin supplied by that nerve. That single mechanism explains everything clinically. The rash is dermatomal, it is unilateral, and it never crosses the midline. Before the rash appears, patients develop a prodrome. This includes localized tingling, itching, burning, or sharp neuropathic pain. This pain often precedes the rash by 1 to 3 days and is a key diagnostic clue. The rash then appears as painful grouped vesicles on an erythematous base. It follows a single dermatome and is strictly unilateral. Certain variants are exam favorites. If the trigeminal nerve, specifically the ophthalmic division, is involved, this is herpes zoster ophthalmicus. Patients may develop eye pain, vision loss, keratitis, and corneal anesthesia. This is an ophthalmologic emergency. If the facial nerve is involved, this is Ramsay Hunt syndrome, also called herpes zoster oticus. Patients develop ear pain, vesicles in the ear canal, and ipsilateral facial paralysis. Diagnosis is usually clinical. The classic unilateral dermatomal vesicular rash is sufficient. In atypical cases, confirmation can be done with PCR or direct fluorescent antibody testing. A Tzanck smear may show multinucleated giant cells, but it cannot distinguish herpes zoster from herpes simplex. Treatment must be started early. All patients with shingles should receive oral antiviral therapy. Valacyclovir, famciclovir, or acyclovir are first-line options. Intravenous acyclovir is reserved for patients with visceral involvement, central nervous system disease, or severe immunosuppression. Adequate analgesia is essential. Never give aspirin due to the risk of Reye syndrome. The most common complication is post-herpetic neuralgia. This is persistent neuropathic pain that continues after the rash resolves. Risk increases with age and delayed antiviral therapy. Disseminated disease may occur in immunocompromised patients and can involve the lungs, liver, and brain. Prevention is critical. Recombinant zoster vaccine is recommended for adults over 50 years of age and is preferred due to higher efficacy. Here is the key takeaway. Herpes zoster is pain first, rash later. It is dermatomal, unilateral, and does not cross the midline. If you see that pattern, the diagnosis should be immediate. This is the Why Medic. Subscribe for more high-yield topics.